excuse me. Is there anyone on the call who has not been looking at the Johns Hopkins um, School of Public Health, the map that the global map that they've put out? Please click into it if you are continued to be interested. I didn't bring it up today. We've got 3 or 4 screens going. I'm not going to bring it up now, but just Google Johns Hopkins COVID map. You can look at the whole world. You can look at incidents. So for example, what this map doesn't show us is if we say Montana or Missoula has 40 cases or has had 40 cases, it doesn't compare that to the size of population. Our numbers are low enough that we aren't really doing that yet in Montana, but you have to compare that to the population. Obviously, if Bighorn now has 41 cases, I'm on a different map here. Let's go back to this one, and has a much smaller population than Missoula, they have a much higher incidence rate, much higher incidence rate. We just have to take the number of cases per 100,000 people in that county, and you're going to see their incidence rate. So when New York City was being hit as hard as it was hit, and we know that there were cases that were not ever caught, may not ever be known without really good antibody testing, they had an incident rate at one time that was, 10%. It was really high. It was really, really very high. And ours was, teeny tiny. So again, that's comparing it to population. And this is what this map and the statistics don't show yet, are the, excuse me, I opened something else. So their incident rate, much higher. The other thing we look at is what's called a reproductive rate, or it's called R0, which is an R0, or an effective reproductive rate. And that is a number that tells us at that time how many other people that one positive case will infect. And we've been working with the University of Montana School of Public Health, which is actually the School of Public and Community Health Sciences. And they're epidemiologists on the faculty. And they were running, when we had active cases, a reproductive rate for us. And our reproductive rate was just over 1. So when you have a contagious disease and the reproductive rate is over 1, it is propagating. 1 is your marker. When it falls below 1, it will eventually extinguish if new cases aren't brought in. But of course, new cases are brought in. So if we shut down Montana again, we would, go down low again, and our effective rate would fall below 0. And then some of the forecasting you've seen is based on that R rate. So you can say this is how many cases Missoula had when we were at an R0 of 1.18. So when we were propagating cases, we never went higher than 1.18, which is just barely over 1. If you look at the Johns Hopkins map and you go back to look at China, look at Italy, look at New York City, and look at their R0, their reproductive rate, and they were just, somewhere as high as 4. So very high. So for diseases that we already know about, we know what their potential is, their R0 or their R0. Measles is the highest, and that's 14. So every measles case that exposes susceptible people that have not had the vaccine, can infect up to 14. Well, here we have a novel disease, novel virus. We are all theoretically susceptible. So that R is going to change in every setting. And so on the cruise ship outbreaks, they had R0s of, 6 to 8. Again, they were basically had created an incubator on the cruise ship. So it's a very effectively spread disease. it spread much more easily than influenza. And we're all to some degree susceptible. So that really drives those numbers. Okay, I'll try again to shut up and try to answer some questions before we just look at some local numbers. So just unmute. Yep, hi. Yeah. Well, first of all, I hope there isn't a buffet breakfast yet, but as we're starting to open up, because those are the more dangerous, close range. But you know, opening up looks different in every county right now, largely based on perception of risk, local controls, and other things. You know, you have to make your, obviously, I have to start with that caveat. We all have to make our own decisions. And we all have, however scientific we are, I think we all have ways as humans that we have learned to accept some risks as part of daily living, such as driving, and not accept other risks, particularly new ones. I from listening to the experts, and I'm pretty absorbed in the JAMA, Journal of American Medical Association interviews. They really believe that other than the contact tracing control that a population the size of Missoula can do, a population of New York City cannot. You can't. I mean, you cannot contact trace every single. It's too labor intensive. But and other than actually shutting down, that as long as we do not have a very effective treatment, very effective, very available treatment, or a vaccine, those of us at 65 and older, with or without underlying health conditions, have to watch out for ourselves. And that means that 6-foot distance, being able to control that around you, and the duration that you might be in contact within that 6-foot. That's really what it means. That is how it spreads. It may also spread through stool, because we know the virus is present in stool. We actually see that more in children, but we don't know much about, you know, finding the virus in a body fluid does not necessarily mean that it's at an infectious dose. So the equation for infection is an infectious dose, and it's different for every disease, and it may be different for every person based on your own, you know, your own health status, proximity, and duration. That's the equation for infection. So, you know, going to places that they do, and I do editorially use the word respectfully use cloth face coverings, that will protect you. Will it protect you 100%? No. But that will protect you. Those types of things. Mm-hmm. So my message on masks is the one that is evidence-based from the Centers for Disease Control, as well as the World Health Organization, because we know we've had some political interference with the Centers for Disease Control, but I generally still trust the people in the entity, speaking for the entity. I think it's very unfortunate when something gets turned into that kind of a political symbol. Whether it's vaccines or masks or whatever it is. I have to be careful, because you've provoked me quite a bit for a non-morning person. in what I say, but that does make it very, very difficult. And if it were just protecting yourself, you might be able, or I might be able to say, okay, fine, don't protect yourself. We know we've got, but it isn't. It is absolutely protecting other people. Wearing that mask, here's mine, right? I mean, you put that on. Are you totally protected if you're standing here talking to me? Well, if you're 6 feet away, but if you spend 2 hours in the office with me and our masks get wet or they have gaps in them or whatever, we touch things that we shouldn't, we don't sanitize, yeah, your protection level goes down. But when I put this on, it's not to protect me. It's who I'm passing in the hallway. It's who I'm sharing the break room with. It's who I'm seeing in the store. And so I find it very counterproductive, dangerous, and actually disrespectful. This virus, we're talking about political boundaries here because that's how we operate politically. But we've already talked about sort of regional boundaries. We're closer to Idaho than we are to the Crow Reservation. And so the virus obviously doesn't know any of that. And the virus sees us as a community to propagate in. It sees us humans as a community to propagate in. That's what it does. And so if we don't see ourselves as a community, and we start seeing ourselves as, well, I'm part of this tribe, or I'm part of that tribe, or I'm the anti-mask, or I'm the don't tell me what to wear and you're just trying to scare us tribe, then we have failed to see ourselves as a community, and the virus's vision will go forward.
Hi, Ellen. This is Lynn Tallarico.
Hi, Lynn. I want you all to know that Lynn was absolutely key for, 15 months on end during the H1N1 pandemic, with most of you don't remember, I bet. And it's because it was influenza, and it mostly affected children, and we had a vaccine. But Lynn could tell you that she worked daily, long days with us to get that vaccine into the kids. It's great to see you.
With the clinics, yes, thank you. It was an honor working with you. So my question is, you named these symptoms during this allergy time with scratchy throats, runny eyes. So would you need to have persistent for days a scratchy throat, or more than one symptom to call your provider to think you'd need to have a test?
You don't have to have more than one symptom. There's so much evidence. Again, there's no metrics, useful metrics yet on all the evidence. I should call it hypotheses instead of evidence. That the symptoms can be so mild that some people don't even notice that they have them, and that may be being confused with asymptomatic, and it may not be, because the only symptom that is not subjective really is the temperature. You can put measures on, your oxygen level once you get that bad, but when you're just at home and you're not sure if you're feeling well or if you should be checked, there's a lot of subjective judgment going on. And so you really have to rely on your own. I always feel this way for at least one night when the lilacs come out. But I wouldn't go further than that. There's absolutely no reason to. There's absolutely no reason to. You can even get a free test. Advise people that are concerned, or even if you have health insurance, you may be dutifully trying not to overuse your health insurance. That's great. But come to our drive-through clinic. We've got it down to, you're going to drive through and it's going to take you 8 minutes. We have it down to 8 minutes. You're going to get that test. Now the limit on the test is it's only good for that one, that day that we tested you. So you could go out a week later and actually get infected. So I'm in the age-related high-risk group. First sign of a symptom, I will get tested.
Thank you. And Ellen, what are your thoughts about traveling, flying within the U.S.?
Yeah, That really does come to your own judgment call, because you don't really know how full that plane's going to be. And so you could definitely be in a non-6-foot distancing situation for hours on end. And I know a lot of them are considered empty now, but I come from a family of commercial pilots, and some of them aren't. You know, they're finding ways to fill the plane and cancel other routes. So if you're going to be uncomfortable, based on your risk assessment, that you're going to be sitting for maybe 3 hours just across country right next to somebody, then you have to make the judgment to not do that. And then, we're all faced with that right now. And also looking at where you're going to, what airports you're going through. I think you're less likely to get trapped in a quarantine somewhere at the moment. So when we were during the shutdown, there was such a hodgepodge of where you could travel, or if you could travel and be quarantined, or if they were going to take your temperature at the airport. I don't think you have to worry about that right now, but come fall, I would definitely look at where the activity is before deciding to travel.
Thank you.
Ellen, I'm going to get out of your screen share so we can see each other, okay?
Yeah.
There we go.
Yeah, I had more files, but they disappeared and I talked too much. So let's just do more questions until you run
Okay,
out of
Sandy?
time.
Yeah, I
Sandy?
have a question on the PCR test versus an antibody test. Are they the same?
No, they're very different. The PCR is actually looking for, so the virus is RNA, it invades your cell and it uses your cell to make more virus. And then those cells are infected, so that's a DNA. And the PCR is going to find that particular infected DNA related to that virus having done that. And the antibody test is a blood test, and it's looking for markers in your blood from your immune system that you have developed antibodies to coronavirus. And so some of the population-based assessments that are being done is to do a random or a certain type of sampling in a large population center like New York. They're doing some of them on the blood supply, in fact, to try to get a sense of what percentage of the population in any particular area actually was infected and now shows that they were infected. That doesn't mean that they are immune or that they're immune forever. The main caution from infectious disease specialists right now, and our infectious disease advisor is over at St. Pat's Hospital, it's Dr. David Christensen. And their main caution with antibody tests is on an individual level, there's cross-reactivity between other coronaviruses like colds. Colds are coronaviruses. Mm-hmm. So you could get a positive antibody test, think that you had COVID, but that test really can't delineate if you actually had this novel virus or if you had a cold virus.
Thank you. Another question about the opening in August and then finishing right before Thanksgiving. When I think about the flu season, I think of it starting before November. So I was wondering if you thought that made sense.
Well, it can start early. And we have had, as I said earlier, we have had people that got flu elsewhere and kind of brought it, sort of in a pod, usually on the same cruise or the same trip. But it generally doesn't start early. The flu shot season starts early. But the flu season, for it to really it could start in October or November. It generally isn't going to be highly prevalent at that time. And then once you start getting around after Thanksgiving and Christmas, definitely. Now, big caveat there, because it's the flu and it can do what it wants to do. Mm-hmm. But that would be an pretty early flu season.
Okay. Thank you.
Yes, thank you so much, Ellen. This has been extremely helpful. So my Zoom Friends group has a bet going. it's kind of gallows humor, but we're trying to predict when the second wave will hit. And I realize you're not a prognosticator, but I'm curious what you think. The consensus is that November 1st may be a danger time because people are coming back together for school after traveling extensively. Do you think my friends group is being overly pessimistic? Care to wager yourself? Or?
Well, I don't, I think I said earlier, you don't know what a pandemic's going to do until it's done it. However, there are things that we need to anticipate and are anticipating. And of course, a second wave, we are anticipating. Absolutely. And if there's any seasonal effect, even with a seasonal effect, which we may be experiencing now in this part of the world, we're still seeing flu. So if there is a seasonal effect, we're still seeing COVID. Why would we, cease to see it in the fall? We've got people going back to university, going back to school. Dr. Fauci is like, be ready for the fall. I mean, if anybody's going to look at a crystal ball, he's got the best one. So we anticipate it, and we'll gladly eat our hats if it doesn't happen. I'd eat a dozen hats if it doesn't happen, but we're standing ready for that. The other thing about a peak, especially with a 14-day incubation period, is you don't know you've hit it until you're on the other side of it. And so when you start going back down and literally trend down, not just a daily, relief, it could be 14 days after it actually really started going down. And so your data are that old. And one other thing about a peak is it's like, oh, we hit the peak. Well, that means you're so if you had 70,000 deaths or something somewhere, that means you got 70,000 more before you get back to the bottom. So, it's, I think we're all pretty worried about that.
Thank you.
Okay, Ellen, well, it's 9:30 and our formal deadline is 9:30. I see Wolf asking one last question, and then we'll let you be free if you want to.
Ellen, could you talk a little bit about the childcare situation in Missoula? I know that a number of childcare providers were forced to close down, and I'm a little worried about where we're going to be this fall if that wave continues.
Yeah, that is such a dilemma. When the schools closed as abruptly as they were closed, that definitely sent a lot of families and kids scurrying into other arenas. And I don't argue one way or the other on that. The medical historians are still arguing over the 1918 flu. So I figure, they can argue over, should have been done that way or not. But childcare is already so marginally vital or viable, and some of them shut down because they wanted to shut down. They didn't want to. They felt it was a safe thing to do. Some had to shut down. And at the same time, the very same time, we were opening childcare for essential workers. And I don't have an answer for that. I only have the observation is there are some things in this world that we are going to have to continue to do. And we're going to have to figure out how to conduct childcare. And our childcare system is, got a lot of heroes in it, but the system itself is just really, really, really fragile. If we put too many more demands on them, they may not be able to pull it off. If we don't put enough controls and protections, we'll take them out, including, their own health. So I think you already know that, but I don't have any sort of, we ought to look at it this way. The only way I think we have to look at it is an essential activity and we need to figure it out. And schools, there's the money that's coming out from the CARES Act is wonderful, but it is woefully inadequate for schools. So even if kids are not highly affected, teachers are. So those are the kinds of systems that we generally don't invest in very much as my political belief. And those fractures they're starting to show. during this pandemic.
Okay, Ellen, we have a few more questions, but before we get to the Owens, Jim, I'm going to make you the host because I have another commitment. I have to leave. I think if I make you the host, I can sign off and you all can continue. Okay? So let
Yeah,
Wolf, should I make you the host? You want me to make Wolf the host?
you don't have to do anything once you're the host. You're just the,
All you do is end the meeting.
yeah.
Well, never mind. I'm already down to Wolf.
All right, we'll wing it
Okay,
from here on
Wolf.
out.
You're now in charge. Okay, and I'm signing off. Goodbye, y'all. I appreciate it. Thank you very much, Ellen.
Hey, Earl, you had a question.
Not a question, but a comment. Interesting, the number of cases in Bozeman or Gallatin County, because there is a man that lives there, David Quammen, who has written a very, very interesting, I would even say prescient book called Spillover. And it's exactly about what we're going through now. It's fascinating and chilling, really.
Yeah.
So I would really recommend it. I see a lot of people nodding their heads like, yeah, that's the real deal. So anyway, Spillover, David Quammen.
Thanks.
Do we have any other questions? Kathy?
It's not so much a question as just to have Ellen sort of back this up, because when you talked about the influenza and the fact that it comes a little later and the vaccine comes earlier, I just want to advocate for everybody in this group to do their flu vaccine the minute it comes to town. Get it done in August or September. It takes 2 weeks to get full immunity. And as we look at where COVID may or may not be, if you have your flu vaccine, it's like putting your mask on. It's not 100%, but it's a percentage worth having. And the sooner you get it, the better it is. And years ago, they used to tell people to do it later and later, and that's passé. Do it now. And I would just ask Ellen if she would agree.
Oh, well, Dr. Rogers, you're the expert on that, and I totally agree. Get your flu shot no matter what's going on, but definitely diagnostically, the flu is going to really complicate the picture.
Ann?
Thank you, Ellen. I have a question. Your position on asymptomatic infectors.
So the hypothesis that's more generally accepted, or at least minds have been left open to it, is that there can be asymptomatic infection. I think there's just a lot of qualifiers to that because the symptoms can be so mild, particularly in a lot of younger folks, that maybe there were symptoms if they weren't subjectively judged. You know, I mean, and until we know that it can't be spread asymptomatically, I think we have to take care that it can be. And I know there was quite a kerfuffle yesterday when that statement was issued somewhat differently from the World Health Organization. So we don't really know how big of a role it plays, but again, as studies look back, they'll be able to understand that better. But when the symptoms are as subjective as they are, or subjectively reported, I would think as a nurse, diarrhea is not that subjective, but you know, you have to ask the patient, did they have diarrhea? Well, they may not want to tell you, right? Depending on the age.
Amen.
So that I think we have to take care that it, you know, it might be pre-symptomatic spread, which is very common with infectious disease, or just very mild symptoms.
And follow up, what then is the impact of testing people as they come in for temperature and so forth? Do they potentially miss a number of people?
We're trying not to miss people now. So that's again the messaging we're trying to put forward, and by having a free testing site where you don't have to think about, do I go incur a medical bill? And is we in public health want to find them early. I mean, we want to find them right away, because we need to identify them and then everyone that is a contact. And when some groups, particularly some age groups, can have 50 or 60 contacts easily in 2 weeks, and all of those people are potentially infectious if they actually got the disease. So that's our main control strategy. So we do want people to come in, and we encourage providers to not say, let's not test. That is a good way to operate, to not over test generally in medical practice. Lots of diagnoses are made presumptively and correctly without testing, but in this case, from public health, we want the test.
And one final quick question. Does the Bighorn situation represent a interesting study? Are anyone working or not in that area?
I don't know if RNOT's being done there. One of the problems our epidemiologists, our volunteers from U of M, is our own population is so small that computing the RNOT it's got a pretty wide margin of error. That population,
I appreciate that.
Yeah, that population being even smaller.
The sample size is very small, but
Very small.
The uniqueness of a semi-closed community there makes for interesting tracing and testing.
Right.
Thank you.
Thank you.
Well, Ellen, knowing how busy you are these days, we should probably let you go. On behalf of the group, I want to thank you for the time you gave us and for all the information. It was very valuable.
Oh, thank you. And thanks for letting me opine on masks. And I see Larry White. I want to say hello. And it's good to see all of you. Thank you very much.
Thank you.